Specialty Story, session number 102. Whether you're a pre-med or a medical student, you've answered the calling to become a physician. Soon you'll have to start deciding what type of medicine you'll want to practice. This podcast will tell you the stories of specialists from every field to give you the information to make sure you make the most informed decision possible when it comes to choosing your specialty. Welcome to Specialty Stories. My name is Dr. Ryan Gray, your host here every week, where I get to talk to physicians about their specialty. And in today's case, a program director about his program, Anesthesiology, Residency Program Director, Dr. Ryan Matika. We talk about what he's looking for in his applicants, what he's looking for, what he has his residents look for when students are doing rotations, and so much more. So we're going to dive in and find out when Dr. Matika first became interested in anesthesiology.
I personally got interested in anesthesiology when I was probably a second-year medical student. We had a one of these programs where you're assigned a mentor, and my mentor through medical school happened to be an anesthesiologist. I went into medical school not thinking about anesthesiology. Actually, I was thinking more of internal medicine. But through my rotations, I was kind of drawn towards anesthesiology and probably started thinking about that about halfway through my third year because of that mentor. I always
hear that from people and kind of anecdotally. It's like, oh yeah, my mentor exposed me to that. And I'm always like excited about that because I think mentors are amazing. But there's always a part of me that's like, is this truly the specialty that you were supposed to go to, right? Or did you just get led down this path because of your mentor? I always wonder if we're doing people a disservice in some way.
Right. Yeah, that's true. I'm not entirely sure. I think, we talk a lot about, personalities and specialty. And I think there's a lot of people kind of poo-poo on that idea, don't like it. But I actually think that there is a major element of picking your specialty based on the personality and that element of finding your people. You hear that a lot with anesthesiology as well as other specialties.
Yeah,
that it's the right fit. Obviously, there's a certain type of personality that's better fit for a specialty than others, but I don't think any specialty has one personality. But,
so you like those flow charts of, do you like people? Do you not like people? Right. Do you like the dark? Do you not like the dark?
Right, exactly. I think that's there's a little utility in there. Probably just not as much as, it's obviously it's tongue in cheek, but there's some truth in it.
Yeah. So what traits do you think lead to someone being a good anesthesiologist?
I don't know if there's like certain traits. The longer I've done this and the more I think there's traits to being a good doctor, and those traits pretty much transcend the type of residency. So I think a good surgery resident, a good psychiatry resident, a good anesthesiology resident, they all have a lot of things in common, which are, I think, probably more than anything else, and often not talked about is kind of your attitude or just general. What drives you? What gets you up in the morning? Do you want to do good in the world? Do you want to work hard? And that type of work ethic and that attitude of positivity is probably not the right word, but let's just say a positive work ethic and a positive drive, I think makes good residents. For anesthesiology in general, we typically get, we're kind of meticulous. We're a little bit OCD, but I don't think that's necessarily absolutely necessary. But you'll see a lot of OCD type of, and a jokingly OCD behaviors among anesthesiologists, doing everything the exact same way every single time. So nothing gets missed or we don't have any unnecessary errors.
I'll take that from my anesthesiologist and my pilot.
Correct. Yes.
So let's kind of break down some anesthesiology myths before we go any further. I think
Sure.
a lot of students have this idea that an anesthesiologist puts the patient to sleep, opens up solitaire, and then when the surgeon says, "Okay, wake the patient up," that's what you do. What is an anesthesiologist doing for the most part during the day, whether they're
Any
doing procedures and
self-respecting
stuff?
anesthesiologist will do a crossword puzzle and not solitaire to begin. But so for anesthesiology, I think that is a misconception, and part of, I guess, there's a show to it. I think any specialty has a show to it, and in anesthesiology, you're always a consultant. Patients don't come to see you, and your services are requested by surgeons and such. And part of the show is looking calm and not trying to blow things out of proportion and keeping an even keel. And that's something that I think gets misrepresented by making it look easy. I think is part of the specialty, but what an anesthesiologist is doing is obviously one of the most important things is delivering the anesthetic that is essentially rendering someone in a medically induced coma to tolerate surgery. But also during that time, you're managing the patient's physiology. Most importantly, the cardio and pulmonary physiology, meaning that we render people apneic. We give them medications that make them very hypotensive, put them into all kinds of cardiovascular difficulties that you have to manage them through. So the anesthetics we give, I think the easiest way to think of it is necessary poisons, and the management that we do is try to offset those poisons in a healthy patient and an unhealthy patient with chronic or significant or uncompensated disease. It's even more tricky. But a lot of our job, the things that we're thinking of, I'd say the majority of the time we're thinking of things to do with physiology and vitals and such, and a little bit less than one might think that we're thinking about ensuring that the patient's under a medically induced coma, because that's actually, we've got good data of how to do that and to ensure that they are asleep throughout the surgery. But a lot of your time and focus is based on the physiology.
Okay. So let's talk about the actual residency journey. So an incoming medical student or incoming intern at this point, what does the training path look like at the beginning to the end of residency?
I see. So the first year is there's two types of programs. There's a categorical program, and then there are advanced programs. In the good old days, almost everything was advanced, and then categorical has gotten more popular. The difference is how you treat that first year, that intern year. About 75% of the spots right now are categorical, means that when you match with an anesthesiology program, you're doing a 4-year program, but that first year is essentially mostly off-service rotations to meet the qualifications of your intern year, which is essentially, not technically, but essentially either a medicine year or a surgery year. An advanced year is a year where you match those two years separately. So you have your intern year, where you will either match usually into a medicine, transitional, or surgical year, and then you will start your formal anesthesiology 3-year training afterwards. So during those 3 years, your first year, I call it getting your sea legs. It's kind of doing the same sort of cases over and over again. You do more simplicity, a lot of airway work. You're getting your basic skills that you need for anesthesiology. During the latter half of your residency, you're doing subspecialties, much sicker patients, and cardiac cases and OB and such. And so through each program has a slightly different way of doing that, but essentially there's a lot more similar than there are differences. And so after 4 years, you've met all of your requirements, and then you can sit for your final written boards.
For someone who is looking at anesthesiology because they they like the lifestyle, they like the operating room, but they're just unsure of their manual dexterity for procedures. What would you say to him or her?
I would say by far the most important thing that you have as an anesthesiologist is your mind. And it's, the cerebral side of it is the hard part. The procedural side, anybody with two hands, we can train to do the procedures. It's one of these things where there are people that are just more talented with hands, but you do the same thing over and over and over again, you'll get it. I've never seen a resident not complete training because of a procedural aspect. Our problems with residents are going to either come in 90% of the cases, either with medical knowledge or professionalism. And as far as I've been part of, 0% with procedures. There are certainly some people who are better sooner than others, but everybody will get there.
Now, you're the program director for an anesthesiology residency program. You're the one making the decision who's coming, who's not coming.
Correct.
When applications start landing on your desk, what is piquing your interest? What is turning you away from applications?
I see. I think there's lots of variables, and I can speak for myself, and I can kind of speak for in general. Because this is something that's been discussed quite a bit, with our meetings and such. I think one thing that's really changed the way that a lot of people have, maybe not changed significantly, but changed somewhat the way that you think about applicants, is we have a basic exam, which is part of the American Board of Anesthesiology, and it's done during your PGY, at the end of your PGY 2-year. You need to pass this exam to be able to complete your residency, and nobody wants to hire a resident and have to fire them because they can't pass an exam. So first and foremost, like just about every specialty, we always look at your USMLE scores. Those scores, essentially tell you how good you are at studying and passing an exam. And so many programs will have a certain idea or a certain average score that they're looking at, and if you have a lower score than that, you'll have to make it up with different qualities. But that certainly is the first one that we look at. Other things, I'm a little bit more pragmatic than maybe your average person, but not necessarily your average anesthesiologist. And so I look a lot at the dean's letter, which is essentially your medical school transcripts, the comments made, the grades that you had, especially on your clerkships. All the clerkships are important, but certainly we look maybe just a little more carefully at your medicine and surgery. Those are things that I think a strong rotations clinically and doing well kind of offset that one single exam, and that's something that's fairly important. Letters of recommendation are always nice. Again, most people have positive letters of recommendation, and there's different interviewers were put various levels of strength on that. I think that's a little bit less important than those other two. I think another thing that's sometimes underestimated is, for me at least, I like to see medical students that are volunteering, getting involved with different activities at their medical school or local communities. I think that's important. I also think that shows a little bit of character, as well as not only character, but when you take your grades and your scores and all that into account, well, how busy were you? What were you doing, during your medical school time beyond just studying and thinking about getting the best grade possible? And I think that's something really important. Research is kind of the same thing, again, not necessary, but it's if you're doing research or involved in projects, I certainly take that into account when I'm looking at grades and scores. And I think that all means something. It doesn't necessarily overcome a bad score or a bad grade, but I think it's really hard to have bad scores, bad grades, no research, no volunteerism. That's something that's really going to be hard to justify.
Those are typically the students who are still applying to neurosurgery because that's all they've wanted to do, and they're just like, I'm going to keep going. Oh man,
exactly.
I think the medical student or even the pre-med student listening to this who hasn't really done a lot of research into what it's like to be a resident or apply for residencies, freaking out. They're like, it's just like applying to medical school. I need letters of recommendations. I need to be volunteering. I need to do well on my tests, and so it's just a lot of the same stuff.
I think the volunteering and such it's pretty easy to do, and I'm not not trying to stress anyone out, I suppose, but I think there's free clinics and there's all kinds of things that you can do as a medical student, and we all know that the really engaged medical students are sending out emails trying to get people to help them, and to have not done anything, you're kind of avoiding avoiding a lot of opportunities. And I think, there's no test. There's no single test. Are you going to be a good resident? Are you going to be a good team player? But these things are just little inferences.
What is the kind of push to make USMLE a pass-fail test and a big kind of trend among medical schools to market themselves and become more favorable to students is to be pass-fail medical schools? How is that affecting, or how will that affect your ability to evaluate students?
I think it makes it more challenging. It's certainly a disservice to those students that have really put a lot of effort into their schoolwork and put a lot of effort into their exams. It's certainly a disadvantage in that respect. The medical schools probably, I don't know a percentage, but a large percentage of them have already gone to not giving you a class rank, going for mostly pass fail, which has the opposite effect as what they were going for, because then you're left with one thing, which is one number to tell you their academic abilities, which is this one score on one day. And it's almost had the opposite effect instead of a positive effect, in my estimation. Making the USMLEs into a pass-fail, it's fine, but now we're going to have to put more emphasis on different factors. If they still have grades on their clerkships, you can kind of infer there. But it's certainly, as a program director, we want more information, not less, not only, just so we can, not only so we can select the residents that we think will be most successful, but also, frankly, not for people to waste time. The board exam process is very challenging. It's very difficult. We have a 4-exam process. It is not something to be taken lightly. It's very unlikely for you to pass through your anesthesiology boards if you really can't get through your USMLEs or barely get through them. And it's I don't think it's really fair to the applicant either.
Yeah.
So that's my take. It's not what a lot of people want to hear, but that's what I think is the truth.
Yeah, it's interesting. I think I agree with a lot of what you're saying, unfortunately. But for a student, a third-year student trying to figure out what to do fourth year, they're interested in anesthesiology, and they're looking at and they're finding out about these things called away rotations. Is that something you, as a program director, you encourage students to do? Is that something where you see students often mess up and they should avoid it? What are your thoughts on away rotations?
I've done these these little round table events with our medical school or our medical students here at the University of Arizona, and I've always participated, and we've had all the PDs from different specialties. And I'm usually one of the few that think that away rotations aren't much help. So I will preface and say that the majority of PDs, although they were not anesthesiologists, do recommend away rotations. I personally think an away rotation only helps you at the program you are interviewing at, and really doesn't lend much. It doesn't really help much when you're going off on your interviews. So I think if there's a program you're really interested in, or if you have a place to stay, you got family, a great friend, or something like that, that's totally fine. But with medical school debt and uh, the financial concerns that we have in medicine, I just don't think that the cost of it to go somewhere and rotate really pays the dividends unless your heart's set in one location or one place. Then I think it makes sense.
Yeah, and I'll add one piece of information that just randomly popped in my mind. I've never really thought about it this way before, but I find, and part of the reason why I have this podcast in general is to give students a broader exposure to medicine and to specialties that they wouldn't get at their home institution. And I think if someone comes into medical school and they're like, I've always wanted to be an anesthesiologist, and then the anesthesia program at their school, at their institution is pretty toxic, and they're like, well, I guess I don't want to be an anesthesiologist. And away rotation might give them an idea of what else it's supposed to look like, or a different anesthesiology programs.
No, that's totally true and totally fair. I think there's a lot of advantages to going on an away rotation. But when my medical students come to me and ask how important is this, and the deans and other PDs and other specialties are telling them it's sometimes important, sometimes critical, I just have a different opinion with them on that subject. And so I wouldn't get stressed out if you can't afford to do it or don't really, medical students with kids and families and such. I wouldn't get too stressed out. If you can, I think there's a lot of utility. It's nice to see other programs. It's a nice way to know the good, the bad, the ugly. But ultimately, I don't think it's. I wouldn't get too worked up over it.
Yeah,
if you can't make it.
For the osteopathic medical student listening to this, wanting to be an anesthesiologist, what would you say to him or her in regards to applying to a program like yours?
I would say that the osteopathic medical students have been increasingly more successful in getting anesthesiology spots over the last 10, 15 years than previously. I think that that you can infer a million reasons why that might be, but that seems to be the trend, and places that previously you wouldn't see DOs, they're now getting spots there. So I don't think DO necessarily is a big disadvantage like it was. There certainly is an element that when you go to an osteopathic medical school, it is more difficult in general to get a residency spot than an allopathic spot. That's I think without question, but it's not much harder. I think that our DOs at our program typically have a little bit higher board scores than the allopathic residents in general. But that's about the only difference, and it's a pretty minor difference. So I think that it's I haven't really seen that as being a huge disadvantage, maybe a mild disadvantage.
When a student is doing a rotation, whether it's their home institution or an away rotation with you, what are you looking for them to be doing to really have an eye on them to go, this is a good student and will make a good anesthesiologist?
Well, I can tell you the thing that I'm not looking at is how well they put a breathing tube in. When the medical students come and they can't intubate, they're thinking to themselves, "Oh my God, I just messed it up." And in front of the PD, it's like that is the least important characteristic that I'm looking for right now, because I have not found a single resident that I have not made into an airway expert quite quickly. And so that's not what I'm looking for. What I rely a lot on the residents. The residents are in the room with them. I like my residents. I want more residents just like the residents I have. I want their interpretation of how they thought they did. Most notably, a lot to do with work ethic, personality. We have a specialty where personality is quite important. And so, again, as consultants, we have to work with other doctors, and we have to have professionalism and such. And so, I think all of these things are qualities that we look for. I think just how well you kind of fit in with us as something to say. And anesthesiologists aren't the most gregarious people, or mostly, maybe not mostly, but plenty of us introverts among the group. And so you don't have to make small talk or be the most likable person in the world. I think just there's a general gestalt that we look for, and it's hard to describe in a single word, or even a sentence. But I think helping out, wanting to know more, asking questions. Why is this? Why is that? How's this? How's that? And just keep on. A lifelong learner, as they say, is extremely important for any specialty nowadays. And just always asking your resident and your attending what they're doing, why they're doing it. And I think another thing that can't be discredited is following directions. One of the issues you get into with any procedural specialty, it's more important to follow directions, or to say, okay, let me take over, let me do the procedure now, than to try to keep going and impress somebody because you can, because probably you're going to end up doing more damage to the patient as well as your application than just following directions. Because again, I think the procedural skills are overemphasized by applicants than they are by their faculty.
Yeah. So you're not having the students suture Swiss cheese.
No, I don't think that's necessary. Although, I think there is certainly there's certainly something to be said for practicing and going and playing with the dummies and doing extra procedures to get comfortable. But
and dummies isn't what you call your residents, right?
No, usually not. No. But that's what they call me sometimes. But but I think when residents first start, they're very uncomfortable with some of the procedures, and they just feel like they've got two left hands, and they'll try to spend extra time in a sim lab or something like that. But again, I even tell them, don't worry, this is normal. You'll get the hang of it. But so I don't want the medical students to worry about the procedural aspect. If they really don't enjoy the procedures, and if they really, they just dread the procedures, again, that's a nice thing to know that this isn't a great fit for you. But you should enjoy it, but you don't necessarily have to be good at it, at least not yet.
Not yet, yeah. When you're looking at applications, personal statements typically one of the parts of the application. What's something that students often put in a personal statement that you're like, I wish they wouldn't talk about this anymore? And what's something potentially that a lot of students miss out on an opportunity in a personal statement?
That's a good question. I don't know if I have a great answer for that.
That's all right.
I think as far as putting in, I think, when you read as many personal statements as we do, you start to see certain trends of personal statements. They usually take on different flavors. There's the classic why I like anesthesia. There's the ones, my personal experience, which drew me to anesthesiology, those kinds of things. I think the most important thing for a personal statement outside of the why and tell me a little bit about your character and yourself is explaining any kind of deficiency in your application. Let's say that you did have that really poor step 1 score, or you even failed it. This is where I really need you to explain what was going on in the greater context. And so that needs to be explained and acknowledged in the personal statement. And when that isn't, your selection committee has to be so curious about you with a deficiency that they want to bring you all the way out to ask you the question instead of it being answered in a personal statement.
Yeah.
Outside of that, I think the personal statement is really a nice place to showcase your personality and what makes you tick. These things are nice to know. Are they absolutely crucial? I don't know. I don't know that a great personal statement really makes up for trouble on the application. But a bad personal statement could raise a few eyebrows and lose you a few interviews. And bad personal statements are going to be things that are too negative, too down and out, or they always talk about you come in bright-eyed and bushy-tailed at the beginning of residency, and you leave, embittered a little bit, and that's just there's some truth to that, but when you're coming in with that kind of statement, it's kind of hard to think that you're going to stay positive and motivated throughout your entire residency.
Yeah,
but you don't see that much. Most people bring a pretty formulaic approach to it, and that's fine. That's not what we want, but that's totally fine, and I completely understand it.
Yeah. Let's talk about what's the kind of the day-to-day life looks like in an anesthesiology resident's life. What does that look like?
Well, when you're on your medical student rotation in anesthesiology, it's you're getting a little piece of it. And the classic anesthesia medical student rotation is you come in early, but you leave early. The residency is not going to be that. You're going to come in early and you're going to stay late. And it's long hours. So what you do as a resident, and actually as an attending, especially if you're doing your own cases, you come in early in the morning. Usually, if you're a resident, you're going to come in and probably give yourself anywhere from 20 to 30 minutes to set up for your case, meaning getting all the medications ready, getting all the monitors ready, getting the equipment prepared. And if you have morning didactics or something like that, that's going to just drive you even earlier. And you're going to do that before your morning lectures. From there, you're going to go see your patient, your first patient of the morning. This patient has been posted for us. It's all online. I'm sure that's just pretty much the way everything is now. And you can look up the patient the day before. Chances are you discuss this with your supervising attending, and you have a plan. And you go in and you see the patient, and you ensure that they're ready for surgery and they're optimized to a fashion that's acceptable. Get their IV in, depending on your institution, and when the room is ready and it's time to go back, you're going to take that first patient back. And depending on which year you are, what rotation you are, if it's a cardiac case or something like that, the setup is far longer. The pre-evaluation is more. There's a lot more to it, and that's how your day begins. Throughout the day, you're going to be doing a variety of cases if you're in the operating room, or even doing anesthesiology outside the operating room. You're going to be doing a lot of cases, and what that means, it's a lot of work. It's a lot of work to stay vigilant. It's a lot of work to get the cases going. They talk about taking off and landing, and so you're going to be doing that for each patient. And each patient needs an individualized anesthetic plan. It's usually, certainly a resident can't get too comfortable with their knowledge and their plan, and they need to really individualize things. And if you're at a tertiary care center, which most residencies are, you're going to have some very complex patients, and each patient needs a careful evaluation. And for the level of a resident, that needs to be done usually the night before, and so they have time to prepare, research, and think about what their plan is going to be. Because again, the simplest part of it is the how am I going to keep them asleep, and the most difficult part of it is how am I going to keep them safe throughout the surgery. And so that's what we want our residents to be thinking about.
What does call look like?
Calls vary greatly among residencies, but calls can be specific to a rotation, or it can be just a general pool for different services. For our program, and probably most programs, we have different rotations have different calls. Our calls for the OR, meaning that you're kind of in the general pool doing the general trauma call, which is trauma as well as any emergency cases overnight. That's going to be usually residents will do one of those 1 to 2 nights a week, and they usually have 1 to 2 weekend nights a week. They will be on call. On average, I'd say most of the time it's probably 2 weekends you're going to be on some kind of call, and about 2 weekdays you're going to be on some kind of call. And that's, I think, fairly typical among anesthesiology programs and residencies.
For the medical student listening to this who maybe didn't do stellar on their boards and is questioning whether or not they can still be an anesthesiologist, which has been their dream since day one, what would you say to him or her?
There are a lot of spots. Anesthesiology, fortunately for the applicant that has had trouble on the boards, there are a lot of spots. There's, I think, I can't remember, 1,500 spots in the country per year. I could be misquoting, but I don't think I'm that far off. And so your chances aren't bad, even if you have some issues. At the same time, once you start getting too low, and I don't really have a number for you, I start getting concerned when students come to me with a score of, let's say, 210 and below, and I'm like, you might want to double apply to 2 different specialties. But I've told residents that before, and they've had no trouble going to absolute stellar top programs. So, it's one of these things that are kind of hard to predict. But I would say that in general, the applicant with the lower board score, I really want you concentrating really hard on your rotations and your clinical rotations. I want you to make that your priority. And the other thing, you need to take a month off after your 3rd year is over and really dedicate yourself to that step 2. Because a low step, a much higher step 2 and a low step 1, that's not a problem for us. Too low step scores, you really get concerned about them getting through the board certification process. And just to give you some more information about every residency in the United States, they're all held to the ACGME and their expectations for board pass rates, and they kind of change what they want every so often, and so it's kind of hard what they want. But one thing that we strive for is, I think the last thing that I heard is that they're going to be looking at the 80% of first-time advanced board exam taking. This kind of changes. Sometimes they're asking you what's your 5-year board certification rate, this, that, the other, and I could just be a little bit off with the latest information. But essentially, we need residents that we know they're going to pass the boards, and that's an unfortunate situation for someone with a low score. If possible, I really think it's important to try to get some face time with someone like myself, some program director, or someone involved in selection committee that has a little more experience in seeing residents like you or medical students like you applying the process and seeing how it went. And barring that, I think the best thing to do is really try hard on your step scores. Make sure you're doing the volunteerism and stuff like that. But there's not an amount of research that's going to overcome this. So instead of volunteering for too much stuff, spreading yourself too thin, I really want you to concentrate on that 3rd year and work really hard and be a good clinician.
All right, there you have it. Again, Dr. Ryan Matika, an anesthesiologist now. He's been out of training now for 9 years. And again, now the residency program director of an anesthesiology program in Arizona. I hope this helped kind of shine some light onto how a program director is evaluating applications, how they are evaluating you when you are doing rotations, and much more. So my goal here is to try to provide as much transparency as possible, as much guidance as possible for you so that when you are applying for your residencies, you are putting your best foot forward. I hope you have a great week. We'll see you next time here on Specialty Stories.
This is MedEd Media.